Hello dear ERMP candidates, welcome to the ERMP and Beyond channel. Today we will discuss a case scenario related to overview of rheumatoid arthritis. Before starting the case, please subscribe, like and write me your feedback in the comment section. Let's jump to the case without further delay. A 24-year-old female patient presented with symmetric, multiple joint swelling of 1 month duration. She has associated morning stiffness and deformity. Her right hand X-ray showed non-erosive osteopenia with soft tissue swelling. Blood test was sent. What is the most likely hematologic lab finding? A. Low platelet count. B. Low C3 level. C. Positive rheumatoid factor. D. Negative ANA. Imagine waking up each morning, greeted not by a sense of refreshment, but by stiffness and swelling in your joints, a stiffness that lingers for over an hour, only to ease as the day progresses. This is the reality for those battling rheumatoid arthritis, a chronic inflammatory disorder that stealthily attacks the small joints of the hands and feet, as well as the knees and shoulders, in a symmetrical onslaught that spares neither side of the body. As we continue, let's consider the young woman who comes to us seeking answers. Her hands bear the hallmark of this relentless condition: symmetric joint swelling, a stiffness that clings to her mornings, and deformities that speak of an internal struggle. An X-ray reveals more than just the shadows of bones. It shows the soft tissue swelling and non-erosive osteopenia characteristic of inflammatory arthritis. The most likely culprit? Rheumatoid arthritis. During a physical examination, what signs betray the presence of rheumatoid arthritis? Synovitis is a telltale sign, where swelling or tenderness in the joints presents itself. One may also observe joint deformities such as swan neck or boutonniere's deformities, rheumatoid nodules, and joint effusions. A reduced range of motion is not just a measurement, it is a quantification of the limitations imposed by this condition. In swan neck deformity, the proximal interphalangeal joint is hyperextended, while the distal interphalangeal joint is bent. This causes the fingers to bend abnormally, with the middle joint straightening and the base and outermost joints bending in. In boutonniere deformity, the proximal interphalangeal joint is flexed, while the distal interphalangeal joint is hyperextended. This causes the middle joint to bend inward and the outermost joint to bend outward. The name comes from the French word boutonniere, which means buttonhole. In rheumatoid arthritis, autoantibodies, specifically the rheumatoid factor, and anti-citrullonated peptide antibodies, are present in about 75 to 80% of patients. Those with rheumatoid arthritis who test positive for these antibodies are known as having seropositive rheumatoid arthritis, a term that carries significant weight in the diagnosis, treatment, and future outlook of the disease. Now, it's crucial to understand that the presence of low RF titers is not exclusive to rheumatoid arthritis. It can also be found in 3% of the general population and 20% of older adults. However, very high RF titers often raise red flags, particularly in patients with hepatitis C infection and other chronic infections. In the clinical puzzle that is rheumatoid arthritis, an RF titer measured by latex agglutination of greater than ration of 1 to 80, or a positive anti-CCP test, can support the diagnosis, but it's imperative to rule out other potential causes. The specificity of anti-CCP antibodies for rheumatoid arthritis is remarkably high, at 90%, with a sensitivity range of approximately 77 to 86%. These figures are not just numbers, they represent a beacon of clarity in the often murky waters of diagnosis. Unlike the ebb and flow of the disease itself, the levels of RF and anti-CCP do not waver with disease activity, standing as steadfast indicators of a more challenging prognosis. Interestingly, anti-CCP antibodies are notably absent in patients with hepatitis C, who may still exhibit a positive RF titer and joint swelling related to the viral infection. Furthermore, a quarter to a third of rheumatoid arthritis patients also have antinuclear antibodies. The plot thickens when we consider other autoantibody responses to post-translationally modified proteins observed in rheumatoid arthritis. While their clinical utility is yet to be fully understood, emerging research suggests that patients with ANA-positive RA may face a steeper hill to climb, with higher levels of inflammation markers like C-reactive protein, more severe joint inflammation, and potentially a less favorable response to traditional disease-modifying anti-rheumatic drugs and biologic therapies. Ladies and gentlemen, as we dig deeper into the complexities of rheumatoid arthritis, we encounter a spectrum of hematologic abnormalities that are not only common but pivotal in understanding the active disease state. Anemia of chronic inflammation is a frequent companion of this condition, subtly undermining the vitality of those affected. Thrombocytosis, an increase in platelets, often emerges, hinting at the silent battle waged within the immune system. Occasionally, we may observe a mild leukocytosis, a slight increase in white blood cells, a testament to the body's relentless effort to restore balance. But the implications extend beyond these common markers. There exists an elevated risk of lymphoproliferative diseases, where the very cells meant to protect us proliferate without check or balance. Non-Hodgkin lymphoma stands out in this category, a shadow that looms over the horizon of possibilities. And then there are the rarities, the medical curiosities that pique our interest. Felty syndrome, with its hallmark neutropenia and splenomegaly, presents a puzzle wrapped in a conundrum. Large granular lymphocyte leukemia, though infrequent, reminds us of the diverse ways in which rheumatoid arthritis can manifest. In the initial stages, radiographs may reveal only subtle hints of soft tissue swelling, a whisper of the turmoil within. As the disease unfolds, a more telling tale emerges: periarticular osteoporosis, the narrowing of joint spaces, and the insidious onset of marginal erosions. These erosions, often manifesting within the first year, are but sentinels of the relentless progression that may strike at any time. Moving on, ultrasonography offers us a window into the very fabric of the joints, unveiling synovial thickening and the telltale signs of bone erosions. It is here, through the lens of power Doppler, that synovitis and tenosynovitis are unmasked, their presence a clarion call to action. Yet, it is MRI that stands as the most sensitive sentinel, its keen eye detecting the earliest whispers of articular inflammation and erosions. But let us not overlook the significance of subchondral bone signals. When we observe abnormalities such as bone marrow lesions or edema, particularly around the knee, they are not mere anomalies. They are harbingers of a progressive disease, a silent alarm that resonates through the corridors of bone and cartilage. Coming to the treatment strategies, we must initiate disease-modifying anti-rheumatic drug therapy, commonly known as DMARDs, without delay. This approach is not just a recommendation, it's a pathway to significantly better outcomes for patients. The traditional reliance on anti-inflammatory drugs alone, such as nonsteroidal anti-inflammatory drugs and glucocorticoids, is no longer sufficient. Now, let's delve into the role of anti-inflammatory drugs. While they are not the long-term solution, they serve as vital bridging therapies. They provide rapid relief from inflammation, buying us time until DMARDs can take full effect. And for some patients, a continued low-dose glucocorticoid regimen may be beneficial. When we encounter flares, the strategy must be precise and tailored. For isolated joint flares, intra-articular glucocorticoid injections can be remarkably effective, circumventing the need for more extensive systemic therapy. For more generalized flares, we may need to initiate or increase oral glucocorticoid doses, always with the goal of tapering down once the flare subsides. The dosage adjustment is a delicate balance, dependent on the initial dose and the flare's severity. In certain cases, a single deep intramuscular injection of methylprednisolone acetate may be the preferred alternative. This proactive and nuanced approach to RA management is not just about alleviating symptoms, it's about restoring quality of life. The clinical presentation of symmetric joint swelling, morning stiffness, and deformity, along with non-erosive osteopenia and soft tissue swelling on X-ray, is suggestive of an inflammatory arthritis. The most likely diagnosis in a young female with these symptoms is rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disorder that typically affects the small joints in a symmetrical pattern, although it can also affect other body systems. The hallmark laboratory finding in RA is a positive rheumatoid factor, which is an antibody found in approximately 80% of patients with RA. This would make option C, positive rheumatoid factor, the most likely hematologic lab finding in this case. That's a wrap on our discussion about the overview of rheumatoid arthritis. I trust you found the insights valuable and empowering. If you appreciated this content, please support our channel by hitting the like button, subscribing for more updates, and sharing this video to spread awareness.